and answer session after that. Colleagues, it will be the usual of putting your electronic hands up, and I'm asking please not for long rhetoric but for questions, so as we can get as much question and answers in as we can whilst we have the attention of our experts. So welcome and thank you very much. And Sam, I think you're going to start off this afternoon.
Thank you very much for the introduction, Heather. Just so everybody knows, my name's Sam Anson. I'm the Deputy Director responsible for the COVID response within schools in Scotland. I should probably highlight these are not necessarily my team, but colleagues that I work alongside. I think that either Eileen or Diane Stockton are going to just give a little bit of a scene setter to begin with. And then I'm going to invite Linda Bald, who is the Chief Social Policy Advisor, possibly, and the chair of the advisory subgroup, possibly to give a quick overview of the subgroup's advice. And then, Heather, we could probably move into Q&A at that stage. So Eileen or Diane, whoever is going to give the presentation, let me hand over to you.
Sorry, I'm just struggling to get things to work. Hi, everybody. It's Diane Stockton here. I think many of you've met me before. I'm just going to try and share just a couple of slides.
Okay. Diane, you are a presenter, so you have got screen sharing privileges. So hopefully that should work now. We weren't clear if it was you or
Lovely. Thanks, David. Can you see that? Can you see that slide? David, can you see that?
Yes, it's all clear.
Oh, great. Lovely, thanks. That's great. Lovely. Right, there's only a few slides, so I'll just quickly whiz through them. We're just going to quickly cover the current context. So that's kind of the vaccine uptake, the Omicron variant, and what's happening at the moment around hospitalizations and mortality. So first of all, you'll all be aware that we've had the booster or third dose out for quite a while now. We're rolling out onto that fourth, that spring booster for our 75 plus and clinically extremely vulnerable at the moment. And you can see the kind of uptake levels of the booster, and it's very important for us to keep monitoring those, because what we do find is the vaccine does wane over time, and it is the vaccine that is really fundamentally changing the situation we're in now. So countries that have had very low uptake of the vaccine, particularly in the older ages, are seeing a very different situation now than we're seeing in Scotland in terms of hospitalisation deaths. So you can see very high uptake of the booster, particularly for the 60 plus age group and the other age groups. The other thing the other important context at the moment is Omicron. So Omicron became the dominant variant in Scotland in December and across the rest of the UK. Is now that was what we call the BA1 subvariant. There's a BA2 subvariant which is now taken over from the BA1, but they're very similar in terms of their kind of severity and in terms of how the vaccines work with those two subvariants of that. What we do know is that Omicron is more transmissible than Delta was, the variant we had last year. But the risk of severe outcomes are substantially lower for Omicron than for Delta. And this is irrespective of vaccines. This is before we put the vaccine into the mix. So you can see kind of the risk of being hospitalised for Delta compared to Omicron. And these HR is a hazard ratio, and they're very much below 1, which means that the risks are lower than for Delta. So 0.41 means that you've only got kind of 100. If that had been 1, then it would be the similar risk, and anything up 0.41 means that only 4 out of every 10 that would have been hospitalised with Delta get hospitalised with Omicron, for example. And then on top of that, we know that the booster, as long as you've had a vaccination within the previous 3 to 6 months, then you're getting high protection against hospitalisation and deaths for Omicron, as you did for the other variants. So 2 very important factors there. And then this graph shows the impact of those 2 factors over time. So you can see here the case numbers in blue. So you can see really high case numbers that we saw in January, and that we then declined, and then they rose again, and we're just beginning to see them tipping down again in the last week. And you can see how that varies to the infections that we had in previous waves, but noting, of course, that we're doing a lot more testing now, so we know about more of the cases than we would have done previously. But then you can look along at the death trends, and you can see that despite much higher case rates, we haven't seen a big change in the trends in death in the red, and for hospital admissions, again, despite the high case rates, we haven't seen, corresponding hospitalisation rates. And the difficulty as well with hospital admissions is that's anyone in hospital with a COVID diagnosis in the last 14 days. It's not it's not only people that are in suffering the consequences of COVID. So that's probably the main data that I wanted to show you. That's just more detail on the case rates and also on the death rates. So we can go into more detail if you want. But I think the main thing was just to show you the change situation we have now with the pandemic, the importance of the vaccine, that within that, that's providing that important protection. Thanks, David. That's all I wanted to say.
Thanks, Diane. So Heather, if it's okay, I might invite Linda to come in next, and she can give an overview of how the subgroup have looked at that data and that evidence and formed their advice based upon that.
Absolutely, that's great. Thanks, Diane, and welcome, Linda.
Thank you very much, Heather. Thanks for inviting us, and also thanks for everything colleagues are doing. I know it's a difficult time, and I can see the staff absence rates in particular at the moment coming through. So I'm just going to take you through, as you all know, the advisory subgroup really provides advice to the Chief Medical Officer's main group and up to ministers. And obviously we've met for many months now, and we agreed that we agreed on our meeting, during our meeting on the 8th of February, that we would look again at the remaining mitigations in schools during our meeting on the 8th of March. And that was with a view to potentially recommending moving to routine measures later in March. And what we'd always aimed for, if you look ahead to the longer term future, was really for educational settings. I also chair the HEFE CLD group to really be aligned with wider society in terms of how we were managing the pandemic. And we thought that that would be an important factor to help people understand in terms of consistency what's required of them across society, as well as encouraging adherence. So what we're very mindful of is that the role of children in transmission continues to point to household transmission as the primary driver. Although we know that obviously colleagues and pupils can pick it up in a range of different environments, including in schools, but there is a continuing low risk of harm to children from COVID-19 infection, and that severe outcomes for all age groups are less likely while we've got the vaccination uptake high, although as we appreciate, it's just really beginning to be taken up in the 5 to 11-year-olds. So we agreed at the subgroup meeting that it would be appropriate at this stage to move to more routine measures in schools and also ELC settings. Now we've got colleagues here working in that area in a proportionate and responsible manner. And this should commence in line with the timetable set out in the revised strategic framework for COVID-19. And as you know, that was to move to removing all legal restrictions after the 21st of March, but given the ongoing high infection rates, the requirement to still wear face coverings in certain settings and in schools for people to be wearing them when they're moving around communal areas on the school estate remains. And then we recommended that all relevant changes that we were referencing should be in place by no later than the return to school after the Easter break. So the main changes really in moving towards baseline mitigations were allowing more parents and other adults to come onto the school estate, including if the school decides for parents' evening. And there was also an expectation of one-way systems, which we know were implemented well in some settings and not so well elsewhere, that those should be removed. But certainly the other issue, obviously we discussed in detail, is asymptomatic testing. And there we really were very mindful of the advice that we were receiving from our colleagues who work on that topic, and the Test and Protect transition plan, which was published, as you know, earlier this month. And that's a tricky issue. I know you're all very concerned about this. I certainly have my concerns as well, but we are in a situation where the funding for routine asymptomatic testing will not continue indefinitely. And in relation to staff and pupils in school, it seems reasonable to remove the requirement to regularly test associated with those settings that has been in place in the past. As you'll be aware, in other parts of the UK, that system has already been removed. And Wales is certainly planning to stop their asymptomatic testing in schools at the end of term. So I'm just trying to see if there's any other points that I want to make. Just to emphasise, as you know, and you're all involved in this, there are quite a wide variety of routine measures that are still in place, and that's also the case in other environments. The requirement or the expectation still to self-isolate, which has never been a legal requirement in Scotland, but guidance, and I expect that to continue to be the case if they have symptoms, are feeling unwell, or if they've tested positive. Or, for example, if your staff or pupils are required to isolate for other reasons, there may be travel expectations there. And finally, if they're identified as a close contact, which would still be the case. And obviously the hand hygiene and surface cleaning measures that you've got, an ongoing focus on the importance of good ventilation. I know that's something that has been a focus, but we need to continue that in future and strengthen it. And then also the fact that staff in some settings at the moment will need to require general guidance, follow general guidance for safety in the workplace. And at the moment that still involves that 1 metre distancing where it's not possible in other settings. And then requirements obviously for face coverings on dedicated school transport in line with it being required in other forms of public transport. And importantly, the ongoing focus on outbreak management, which we'll need to retain indefinitely if there's a major concern in schools as well as in other settings. Finally, just to emphasise the importance and why this meeting is so valuable today of ongoing engagement and communication. I think the way we can keep colleagues and pupils as safe as possible as we're in this new period is really recognising that we need to keep talking about vaccines, keep talking about the protective measures that remain in place, and move to a situation where we can manage the fact that this virus will be with us indefinitely. It's not going away. And I think the science will do its work in trying to spot new variants, which is our biggest concern. And in the meantime, we need to move ahead and really think about the things that you will have as priorities for the coming months, exams, supporting the workforce, and all the other things that you're dealing with. So I hope that's helpful. Thanks.
Thank you very much for that, Linda. It was very helpful. Sam, is there anybody else from your team wanted to speak or present with anything? Or are you happy to go to the Q&A and comment section?
I think we are probably ready to go to Q&A, Heather. So let's do that. And if there are particular things, we can pick them up through that.
Okay, so colleagues, if you would like to raise your electronic hands, if you want to ask a question or make a comment, can I start off with one, if you don't mind? Is that today I forwarded to the members on this call the letter signed by the Professor Leach, the National Clinical Director, which will go out to all parents, carers of young people. And it does talk about when there are no longer twice weekly lateral flow tests, but it does talk about if you have tested positive. So where are these tests to come from if they're no longer going to be supplied by the school? How much do they cost? And how do they expect families who are really struggling financially to buy these tests? And the answer is they won't. And so therefore, do you not agree that this is a recipe for COVID to spread amongst the schools without mitigation?
Colin, I'm wondering if you want to come in on this point, because I think it's potentially, in particular, around outbreak management and the requirement to step up testing in particular circumstances, if and when necessary.
I think the answer to the first question about, so first of all, hi, I'm Colin Sumpter. Hi, I'm a consultant in health protection with the Public Health Scotland, so NHS consultant, previously working with schools last year, a lot around outbreak management, and now in this national role around public health in schools with Public Health Scotland. So in terms of testing, so the asymptomatic testing programme continues until the 18th of April on the current testing timeline, and symptomatic PCR testing continues until the end of April. So testing will still be available along that timeline. So there may still be positive cases identified until that point. Post that point, as you mentioned, Heather, that there may be people who choose to buy tests for their children or for themselves and take those tests. That wouldn't be what we would recommend that they would do, and there'll be advice in place around what people should do with symptoms or with a positive test if they do happen to buy one. So I expect Professor Leach's letter refers to those situations in terms of getting a positive test. Sam's referenced the fact that there may still be instances in which health protection teams think it is necessary to test children asymptomatically or test staff members asymptomatically in response to a specific situation. Now, this is going to be a lot more likely in what we would call high risk for public health harm settings, and that's places where people may be more susceptible to severe illness following infection. We are moving to a stage where viral infection has historically been accepted in society as something that is an ongoing risk. And we are moving to, as was presented before, a situation where we have seen huge improvements in the outcome of COVID-19 infection, particularly in younger working age adult populations due to vaccination. So we wouldn't imagine it be put in place lightly in a school setting, but it is still there in the Scottish Government policy and health protection team advice that if there is concerns around an outbreak in a school, and I think that would be tied to seeing more severe illness potentially in younger people or more severe illness in fully vaccinated working age people, that potentially testing would be reintroduced in the attempt. And that would be in line with lots of other measures to try to reduce the infection in that individual setting. But I think that would be an unusual intervention.
Okay, thank you for that answer. I'd like to go to some of the members now, some of the secretaries. Alison Murphy, first question or comment, please.
Thanks. It's not a large number, but there are some people who are not actually able to take the vaccine because they are, they've been medically advised not to. What are we able to offer for them? Because, a lot of this is around your risk if you're vaccinated is much lower. But what can we do to support people who aren't able to access that support? I'm supporting some people like that, and they are deeply, deeply worried about the possibility of going back to work. So yeah, what can we offer to them? Thank you.
Do you want me to start, Colin, and then I'll hand back to you and maybe Diane or anybody else? So I think the situation will be different for those colleagues in future, and that's because some of the treatments that we have available. So we have antivirals, which largely are being trialled now in the UK. So these are medicines that you can take early on that will prevent severe disease. We also have monoclonal antibodies, and there's a new one that's been licensed in the UK, which will likely be available in future, which are particularly designed for people whose immune system doesn't respond well to vaccines. So that may not be entirely the category that you're talking about. I understand colleagues are very, very anxious, but those are two certainly routes. The other thing I would say for those colleagues is I know it's confusing because early in the pandemic, we talked about face coverings as something we would all wear to protect other people. But it's important to remember that a face covering now, of the sort of FFP2 type that you can buy in the pharmacies now, they're much more affordable, will also protect the wearer. So I think that's an important feature just to keep in mind. Colin, can I just see if you want to add anything there? Thanks.
Yeah, so my role is much more around public health and transmission than it is around individual health. But to talk about public health issues around clinical vulnerability or clinical extreme vulnerability to COVID, I think we've learned a lot more about clinical extreme vulnerability over time. There's a fairly small group of people, but that are there, Alison. I'm not saying they aren't there who can't be vaccinated. The Chief Medical Officer advice for quite some time now has been that they should follow the general population health advice And my understanding is that remains the Chief Medical Officer's advice. In terms of public health measures that might protect them, the difficulty with continuing with community level protection whilst the rest of society is open to protect specific individuals is that it places a very large burden of control on a very large group of people. And it's much more likely that the greater gain would be around placing that control as close to the person as possible. So as was mentioned, household transmission, primary routes of COVID-19 transmission, potentially thinking about how the household can be made as safe as possible, thinking about measures that they can take themselves around COVID-19 avoidance for themselves around face masks, as was mentioned by Linda. But the idea of retaining asymptomatic testing across the whole of society in every setting to protect the fairly small number of people is really difficult element of public health, but it wouldn't be considered a proportionate way to keep going now we're seeing where we are.
Thanks for that. Alison, I'm going to let you briefly come back about the FFP2 masks because you've asked to do that.
Yeah, and that is actually a very good point, because I mean, I'm fortunate in that I'm local association secretary in Edinburgh, who have actually made FFP2s available to members of their education workforce where there is a need. That actually, as I understand it, is pretty unusual. We actually had to fight quite hard, and Edinburgh is, like I say, is a bit of an outlier in that, and we are being told quite strongly that that is likely to be withdrawn, which is something else. So I think actually within exactly what you're saying, if something could come from Scottish Government guidance saying that within schools where an awful lot of the other mitigations that you've been talking about, such as distancing, are very, very difficult, particularly in primary schools, particularly, you know, in special schools, but even just in corridors in secondary schools, distancing even from your colleagues is really hard. Actually, if there was guidance that said where you have someone who is clinically vulnerable, particularly someone who's unable to access vaccines, giving them the option on a continuing basis to be able to have access to FFP2s would in fact be a proportionate measure. That would go quite a long way to reassuring people, because at the moment, most of them can't get it through work. People in schools who are wearing FFP2s, like I say, in a lot of other local authorities, if they're wearing the FFP2s, they've bought those themselves. And to my mind, if it's something in the workplace, it surely should be something that's provided by your employer. And yet most employers are specifically saying, we are being told by the guidance that FFP2s are not required for anyone. So I think for that group of staff, updating that guidance would be a massive help. Thank you.
I see, Chair, I see Diane wanted to come in, if she wouldn't mind letting her respond as well.
Okay, absolutely. Diane, thank you.
Thanks, and nice to see Alison. So we've done quite a lot. So there's two groups, I think, here. One is the very, very small number of individuals that can't have a vaccine. And I think that really is a very small number, and they might not be clinically vulnerable. You know, there's a separation there. And then there's the very extremely clinically vulnerable group. Now, it was just to really point out that apart from that subset, that quite small subset of individuals who are on that kind of different program of third dose, etc., because of their extreme vulnerability, what we found is the vaccine is as effective for most of the other groups. So originally we did have quite a big bucket of people that were shielding, or that we thought might be more vulnerable for if they got COVID. But what we found is that for most of them, the vaccine is effective. So it's just to say that some of what we maybe need to do is more reassurance about I've heard this from people themselves that that is the vaccine working for me, if they have got a history of certain medical conditions. So I just think it's just a reminder to me, as much as anything else, I think we need to make sure that they've been really strong on those comms around that for the majority of people the vaccine is very protective.
Heather, if I could just come in on that really quickly too.
Okay.
Thanks. So I think what we've tried to do within the guidance specifically is to move away from a national top-down, really, really prescriptive approach. So we were previously at around 100 pages of guidance. And to be honest, even then, we weren't able to preempt every possible scenario, to something that's much more around educating, I suppose, and raising awareness across the system of the right type of things to put in place at the right moment. And the system as a whole, I think, has learned a tremendous amount over the last 2 years as to how to do that. So the particular point regarding face coverings, I would absolutely say is accommodated within the risk assessment section, which makes clear that those risk assessments should take place and that appropriate measures should be put in place as a result of those risk assessments. And I think if the employer and the employee are of the view that that is a reasonable measure, then the guidance absolutely does facilitate for that to happen.
Okay, thanks for those responses. I'm going to move on now to Nicola Fisher, please.
Thanks, Heather. Yeah, just a couple of questions and some concerns. I'm not totally convinced, Heather, that your question was answered actually in the beginning, because I think you were asking how do people, you know, if we're being told to self-isolate, how do we know to do that if we don't have testing? So I'm not, perhaps I missed the answer, but I certainly didn't think I heard it. And I think this is hugely concerning. The profession will yet again feel very let down, and we have felt very let down all the way through. COVID is not a harmless disease. It causes cognitive damage to internal organs, eyesight, hearing. It doubles your risk of heart attack. It causes early onset dementia, cognitive impairment, increased risk of blood clots and diabetes. And there's no guarantee each variant will be weaker. We do not have universal vaccination globally, and until we're all safe, none of us are safe. So a lot of this is incredibly disappointing. It's incredibly disappointing that yet again, it's based on finances and politics, unfortunately, in a lot of cases. I think the fact that we are getting rid of regular LFT testing for school staff is a real problem. In our school, I'm in a school where 500 people or more attend every day. We have never had such high rates of absence as we do now amongst both the children and the staff. We have a very robust risk assessment we have done all the way through. We're still adhering to it, but we have not had one single week since January with every member of staff in. In fact, we have multiple members of staff off every week. And this is the evidence in front of our eyes, and yet we're having mitigations being taken away. I recently had it myself, and I was asymptomatic. If I hadn't been taking lateral flow tests, I wouldn't have known. I would have spread it to other people. As it was, I spread it to 2 family members. So it's not just about protecting a small number of people, it's about protecting a lot of people. So, you know, I think it's really disappointing. I appreciate it's not the scientists on this call who can make the decision about lateral flows, but it would have been better for funding to be found for that kind of thing. Especially in terms of asymptomatic spread. In terms of it being continued until the 18th of April, that's not a comfort because we're about to be shut for 2 or 3 weeks. So that doesn't really extend lateral flow testing for us in schools. I was interested in you know, what was said earlier on about we need to keep talking. I think that's really important. How can we do that when SERG is being removed? I don't know if anyone on this call can answer that. I'm also interested in the thing about new variants. How are we going to spot new variants when there's such a reduction in testing coming? How will we do that? You know, if we've been told if there's an outbreak, such and such a thing will happen. How will we know it's an outbreak if there's little or no testing happening? I've seen, I think, perhaps in the transition plan that it says GP stats will be used. I think that might be where I said that. I saw that, but people have been told not to go to the GP with COVID. So how will that inform the situation? I'd like to know if anything's going to be advised about public transport or ventilation, which has been the poor relation all the way through. Very little ventilation on public transport. We're hearing earlier on in some of the remarks that ventilation is key. I would absolutely agree with that. Little or no ventilation on public transport for 2 years. And of course, it's the poorer members of our society who often travel by public transport. We have many children and young people travelling by public transport. Bus companies have been allowed to get away with saying that they have their windows open a teeny tiny fraction when they don't. Train companies have windows which don't open at all. Is there any plan about keeping society and schools safe by ensuring that public transport is well ventilated, especially people are maybe not going to have to wear masks or stop wearing masks because of new guidance? I'm just scrolling through to make sure I've asked everything I want to ask. Other than I think that's probably everything I've got. But this is enormously disappointing. Even if this, you know, a lot of mitigation could have been kept in place until the summer. There's a real lack of confidence from the profession in this situation that has been all the way through, because we have been let down again and again and again. And things, for example, I see some faces that we met a year or so ago on here where we expressed concerns and we were told maybe that won't happen, and then it went on to happen, and a year on here we are with very concerning decisions being made. Thank you, President.
Thank you, Nicola. Really valuable points and a lot of questions in there. I'm not sure, Sam, who you can direct to answer these points.
So I might kick off on 2 or 3 of those, and then I might see if Colin wants to come in, particularly on the point around testing. So in no particular order, the point about public transport, I can't speak knowledgeably or credibly to that, but what I can do is commit to take that feedback away and pass it on to my colleagues. So I'll absolutely do that. There was an issue regarding effectively pressures on the workforce and pressures felt within schools at this point in time due to absence levels. I can assure everybody on this call that I monitor that data as closely as anybody else does. I look at that data on pretty much on a daily basis, pupil absences, staff absences, school closures, etc. We are absolutely reviewing that on a more or less around the clock basis. So we're absolutely aware of those concerns, continue to review what those mean. There's a question around SIRG as well, which I think is a really good one. And I spoke to somebody earlier about this and about how we can make sure that dialogue continues. So although SIRG is temporarily hibernated, I think that's probably the best expression. So we'll not be meeting with Ms Somerville or with Councillor McCabe for the time being. What we've absolutely committed to do is to put in place a SIRG monitoring group, which will meet on approximately a monthly basis. So we'll absolutely meet in April and again in May. And during those meetings, we will go through the data that Diane and Eileen produce for SIRG meetings, and we'll make sure there's a full round of feedback from members into that. So we've got the kind of the system-wide data, but also that collective intelligence, I suppose. If there is anything through that that requires an escalation back to the full SIRG group, then we will look to do that. Equally, if we found ourselves in a situation where there was a new VOC, for example, and the situation took a real turn for the worse again, we would stand SIRG back up again pretty quickly. But at the moment, I think that ongoing monitoring is the best way to ensure dialogue across the system. So I hope that helps on those three particular points. I'm going to invite Colin to come in on the testing because he's got a fairly comprehensive script on testing, which I hope will provide a little bit of confidence and assurance to people.
Yeah, I might go off script a bit, but we'll see where we get to. Nicola, there was lots of questions in there, and I might go beyond testing as well, if that's okay. So I took Heather's question to be about how people will know to isolate for the next few months, for the next few weeks. It's true, testing will be there, but we would still recommend, of course, from Public Health Scotland, that unwell children shouldn't be attending school. So children who do have respiratory symptoms shouldn't be attending school. But I think you all know your experience better than I do, that that doesn't always work. But people with symptoms of respiratory illness, and there's a lot wider respiratory illnesses than COVID, and there's also respiratory illnesses that are more serious for children than COVID, that they will be advised not to attend school. You mentioned asymptomatic identification, and just to say that asymptomatic transmission is less common, less likely to happen than symptomatic transmission. The virus needs a pathway from person to person, and that pathway is through respiratory droplets, and that it is transmitted more commonly symptomatically than asymptomatically. Just to mention about new variants and testing. So you mentioned the identification of new variants. So there's in the Test and Protect transition plan, a comprehensive section setting out surveillance for new variants. So there's still testing ongoing in healthcare, and there's also going to be a surveillance program put in place to identify cases of COVID, as there has been throughout a surveillance program to try to identify without people coming forward for testing, to try to make sure that COVID's identified across the population, not just based only on testing. And those are PCR tests that can be sequenced, and variants will be identified. Variants also have been identified throughout based on international surveillance. So international surveillance will continue. And there is a comprehensive plan there being put together between PHS and SG to keep looking for variation of this virus. You mentioned not attending GPs, but GPs will return to treating, to receiving COVID patients this month, next month. And so that pathway will be reopened. And throughout the pandemic, there's been a GP surveillance program sampling people who do attend their GPs to identify if they have COVID or not, to help us understand not just those that come forward for testing, but how COVID is distributed across society without relying on them coming forward. You mentioned adherence to measures, and I think that's a really key point, and it's really key around asymptomatic testing as well. all of these public health measures have relied on a very unusually high level of adherence. So asymptomatic testing is all about who around you tests, not whether you have access to tests. So by the time you're testing yourself, the public health control benefit is lost. It's not about you identifying your own positive test in terms of you being infected. It's about everyone around you. And we know adherence to testing has been very low. It's been demonstrated that the uptake hasn't been sufficiently high to really get the gains that we would have hoped for, and that I'm sure everyone would want to have seen. And I think you mentioned mask adherence, and it's the same situation there, that mask adherence is an issue across society. You mentioned the person in society, and I'm just mentioning that to totally agree with you. The person in society most affected here in terms of both the measures and also the impact of COVID. And just to say that I agree with you completely there. You mentioned continuing to summer, and it just always seems to be better to stop later, and there's never a good time to stop. What is the sustainability of this? There's a very extraordinary public health measure, the kind of public health measure that isn't used really for any other type of disease in society. So cancer screening is the only comparable analogy that we can think of in public health. When we screen for cancer, we test people who are completely asymptomatic to see if they have an indication, but the outcomes of cancer are so serious that possibly when we had no COVID vaccination, you would say the outcome of COVID infection warranted such an unusual public health intervention. Now that we've decoupled largely that link between infection, hospitalization and death through vaccination, it's no longer appropriate to have such a large scale screening program for COVID. So it's not the same position as we were in last summer. We're in a very different position. And that really is to do with what was presented at the top of the meeting around the decoupling of infection and serious harm. So I probably strayed off topic a bit there, Sam, sorry, but I was trying to cover the ground.
It was useful. Thank you both for your answers. Moving on to Andrew O'Halloran, please.
Yeah, hi, look, members are coming to me and they're confused about the messaging they're getting nationally. What they don't understand is why mitigations are disappearing in society and being reduced in schools when they're seeing in our area, which has had very, very, very high COVID numbers recently. They're seeing high numbers of COVID cases, and we're seeing classes being collapsed and schools closing with a knock-on effect, a negative effect on education and learning. They don't understand why the cases are so high in our area, why there's a kind of a one-size-fits-all approach across the country. And they're also asking me, moving forward, if we've got to live with this virus, what are the cultural changes that we're going to have to bring into force as a society to combat this virus as it becomes endemic?
Thanks, Andrew. Who would like to pick up that one?
Do you want me to start, Sam?
Yes.
I mean, these are really, let's be frank, colleagues, these are really tricky issues. And I think Colin's hit the nail on the head then. When do you stop doing some of these things and how long do they go on? This extraordinary response with huge amounts of public money and effort from all of you as well. And there's never going to be a right time. They've never had asymptomatic routine testing in most countries, including countries that we know well, like Canada, the US. People have always had to pay for those kinds of tests. They've never had what the UK has had. And that includes in educational settings. So it's really, really tough. But I think the decisions about why now across wider society, Andrew, are really around a couple of things, I guess. The power of the vaccines, the huge reduction in severe disease. You can see that from the ICU numbers and mortality figures, which are below the 5-year average still. Even though people are still becoming unwell and losing their lives with this disease. And secondly, the accumulated harms that you're aware of, that we've heard about from yourselves and colleagues in terms of, the harms that lockdowns and other restrictions have caused. But I think you make an important point about the ongoing disruption to education because of absences. And I think that is a big challenge. So we need to think about the longer term. At the moment, the point that Colin made about people staying at home when they're unwell, that's a cultural change. I know people were looking very skeptical because that doesn't happen. for staff or students in all instances, but we need to change our culture there. And we need to think about our built environment, and the points you were making about transport, Nicola, etc. Completely get that. But these are shifts which are required across society, and government, you know, I'm obviously an advisor, government needs to lead on some of this, but so do other sectors of society. So it's a challenging period. Those are just a few sort of more personal thoughts from me that I hope are helpful.
Thanks, Linda. Eileen, Dr. Eileen Scott. Sorry, Eileen, you're still on mute.
And of course, it's like an exam answer. That was the perfect first sentence. What I would say, and I think as Linda and Colin have illustrated, and data we hope illustrated, is that decoupling effect between sort of clinical harm and case numbers. So that will be what you're picking up from us, is less a concern about case numbers and more about actually the impact of vaccination and the fact that that is enabling us to move forward in society. I guess for many of you, you won't know that my background is primarily health promotion, health improvement. And as Linda was highlighting there, what we are seeing and are really manifest impacts in terms of society about the fact that we have had to really restrict people from everyday life for a couple of years, and we are seeing things coming through for children and young people, you know, in terms of access to child health services, child development concerns, you know, increases in the severity and complexity of mental health issues, in particular eating disorders. We know that we're seeing impacts in terms of attainment and loss of learning, and just the wider impacts in terms of health and well-being for all of us in society, and poverty. So I guess those points that you're illustrating about the impact on those who are the most disadvantaged in society, we are acutely aware of, and these decisions have to balance those things. And thinking through, you know, there are often no easy decisions, but it's that comparative balance of the decisions we're taking and the impact. So for children and young people, 2 years out of their life is a huge chunk of their childhood that we cannot return to them. So every decision that we make has to think about what the impacts in terms of they are, and are they proportionate against what we're asking for the rest of society as well.
Thanks for that. Jane McEwen, Fife, please.
Thank you, President. It's really harping back to Alison's initial question about the can't vaccinate, and
Jane, your sound's completely.
You were talking about immunity. Is it? Sorry, I'll turn my video off. Yeah. I'll try that. Okay. So it's really about, Linda was talking about immunity waning after 3 to 6 months, and really for many of our members, we're sort of reaching that point where we're getting past the booster time when our immunity is starting to wane. And I just wondered, at that point, we're also removing the mitigations, whether it be face coverings or the testing. So I was wondering, there doesn't seem to be any appetite for giving boosters to the under 75s at the moment. So I just wondered if we envisage teacher absences falling under these circumstances when they are at this high level, when I can't see them, and do you think the link between infection and hospitalisation might actually reoccur when our vaccination status decreases? I hope you got that.
Thanks, Jane. Who would like to pick that one up?
Diane, Colin.
I can pick that one up.
Thank you.
Yeah, I'll start off with that one. So, yeah, so at the moment, the vaccine is still looking effective, you know, really quite effective against hospitalisations and deaths up to 6 months, but agree that we are expecting to see a waning after that, because that's certainly what we've seen after the first and second dose of the vaccine once you get past the 6 months point. And JCVI are obviously actively looking at whether to extend down the age groups to, as they realise younger age groups are starting to reach you know, that point, and they'll be bearing in mind the time of year as well. And we still don't know for sure about the seasonality of COVID, so there's all these factors into play as well, to, you know, to lining up as we come into next winter in terms of the best points to boost the population. And then just on, you're asking about, you know, teacher absences as more mitigations are removed. The main one probably that you're thinking of is the asymptomatic testing, and I think it's a bit of an uncertainty about what would happen when you remove that, because some people certainly rely on the asymptomatic testing program to almost screen when they've got symptoms, and then probably carry on doing what they were doing, you know, or sending their kid in if they come back as a negative on their test. So you'll get you could end up, if people, it's this change that Linda was talking about, you know, how to encourage people to stay off if you've got symptoms while you've got symptoms is really the key thing here. That's the key. I think Andrew asked the question, you know, what really needs to change, and it really is that that point about, you know, if you've got respiratory symptoms, stay home until they've gone, because that's when you're at the highest risk of spreading, you know, spreading the infection. So that was, so I think you were asking what impact will the asymptomatic testing program have. You know, it could go in either direction depending on how people are using it as a screening tool.
Thanks for that. Paula McEwen, please.
Thanks, Heather. A lot of what I was going to say has already been covered in terms of the fear for some people about the asymptomatic testing being removed. You've talked quite a bit about symptoms and about respiratory symptoms and staying off work. Are we sticking with the cough, the fever, the loss of smell and taste, or will there be an updated list of symptoms, given that, you know, certainly reading widely around this, those aren't the only 3 symptoms of COVID. We all deal with the most vulnerable of our members. If there isn't testing and there isn't a confirmed COVID diagnosis, where does that leave our long COVID sufferers? How do they be diagnosed with long COVID if they've never had COVID confirmed? And where does that leave them? Yeah, I'll stop there. Thanks.
Thank you. Who would like to pick up Paula's point on that?
I could, if that's okay.
Thank you.
Okay. So in terms of what advice would be offered to people with symptoms, I think exactly as you say, it would be a much wider list of symptoms. Essentially, we're trying to stop people going in to settings when they have symptoms of respiratory illness. It's not just about COVID. It would be much wider than that. So it'd be likely that the advice, and it remains to be seen how that advice is worded, but my advice certainly would be that it would be a longer list of symptoms. Staying away whilst you're infectious. I mean, we already have that advice in place, for example, for diarrhea and vomiting from school, as you know, to stay away when those symptoms are present. And I think it would just be expanded for any symptoms of respiratory illness. Children do recover quickly, I think, on the whole, and are infectious for a shorter period than adults on the whole from most infectious illnesses. And so I think it would be a case of them staying away until they were well. I think Diane touched upon the false reassurance of lateral flow testing, and I think it has created an idea that a lateral flow negative means on you go, get into school, doesn't really matter. But a lateral flow negative for a child with flu still sends a child with flu into school. And I think that's a cultural change that was mentioned that needs to be understood and brought on. And there's much more than just flu and COVID out there for these children. We've become very laser focused on COVID. And I think we need to spend some time readjusting that. And that's cultural, as was mentioned. And then the last one was on long COVID. And a lot of studies on COVID do highlight that the symptoms of long COVID around fatigue and general longer term symptoms are present often in people that haven't had COVID when they compare the people who have had COVID with those that don't, when they include a control group in the studies. Those symptoms would still be recognised in people, and those symptoms would be treated as a group of symptoms. it wouldn't necessarily rely on them having a COVID diagnosis to be able to receive help for long-term fatigue. So I suppose that's, I think, the points that Paula had raised.
Thanks, Colin. For those of you who can't see the chat, there was a very good comment there from Matthew about our absence management policies that we have through our employers. They will have to be updated because it's not a disciplinary, but we feel as if we're being sanctioned if we're off sick. So that will have to change. And also, if you make a greater list of symptoms, then are you saying that even young people who have colds, because they won't know if they've got COVID or not, are going to stay off? We'll never have anybody in the classroom, because every teacher knows that we deal with runny nose, snotty wee bairns every day of life. And if it's just a cold, they come in. So there are real issues there, Colin. Susan Quinn, please.
Thanks, Heather. I'm kind of following on from that point and from Matthew's comments, I suppose, which is to say that this significant societal change in approach will rely quite heavily on some work being done with employers to ensure that processes are in place to encourage people to consider differently how they attend work when they are unwell, because as colleagues have commented in the chat, presenteeism and others items are rife. And I think it would be fair to say that we know that parents won't keep young people off who are ill unless they're told they have to keep them off because they've got COVID symptoms, because we know that at the earliest stages of this pandemic, we had to fight in our schools to get young people to stay away. We had parents insisting that their children attend school when they presented with COVID, and fighting with our colleagues about the fact that they couldn't keep them at home because they had to attend work. I'm not blaming the parents, not all of them, some of them maybe, but some of them were put under immense pressure by their employers to attend work. And that's problematic. So this idea that we're going to have a sudden societal shift that will see people think differently about how they behave is just, it's a fantasy land in terms of this. And I think that's what brings and drives the frustration for our members in relation to this. For staff in schools, one of the things that's going to be is an immense pressure to attend work. We already have that. We already, with the reduced mitigations that have been in place up to this point, seeing lots and lots of staff being encouraged, let's use the charitable term, to attend work when they shouldn't have been attending work. And that's not going to go away. And finally, this is one of the things for you to can't be addressed by Public Health Scotland, much like the point from Nicola about transport. That bit about staff attending or not will become even more pressing when there is a removal across all employees, all public sector employees, not just teachers, but ours through the SNCT, but through other public sector workers, of the right to special leave when you are absent because you have COVID or long COVID, because that will then put an immense pressure on staff to be in work because they don't have the sick leave entitlement, which would see them safely stay at home until they are properly well. And that in itself is going to be problematic. And I'll finish with a comment around the fact that we heard there about our young people having lost and the challenges to it. I need to say there's nobody more aware of that than our teachers in school. And the very fact that it's been said here is really not helpful to us, because the fact is that our teachers are now dealing day and daily with young people who are returning from the challenges of lockdown, and that is seeing them experience an increased number of violent incidents and other matters with it. So we know that lockdowns are not the answer. We're not asking for additional lockdowns. What we're asking for are mitigations to be in place in our schools that give us the confidence to be able to protect ourselves and our young people, and then continue with this so that we can overcome all of the challenges that we've faced.
Thank you very much, Susan, and I think every member of this panel endorses everything you've said there. Mick Dolan, please.
Hey, thanks, Heather. Yeah, I came to this meeting late this afternoon because I was at the SNCT meeting, and one of the key elements of discussion was just as Susan referred to there, which is the special leave that was granted in relation to people reporting with COVID. First of all, they've got to be able to test in order to identify that it's COVID. But then beyond that, the special leave did remove the pressure for people then being engaged in the attendance management policies that the local authorities have got, which you yourself referred to, Heather. And those are seen by members as punitive, and will continue to be viewed by members as punitive. I think one of the cultural changes, certainly that I've seen over my working time, that could well do with being reversed, is the removal of the trust in the medical profession to write absence notes and sickness notes for people in a workplace, where they were able to make a judgment as to how long somebody needed to be off in order to gain wellness and go back into the workplace again. That it seemed to be that employers won the day on that discussion, and then it became a fit note, and people are getting pressed to declare themselves fit before the end of the period that they really should be in terms of their illness. So a big cultural change is a re-establishment of the medical profession making medical judgments about people who present to them with conditions as to when that condition would allow that person to go back into the workplace again, because that's been turned on its head entirely, and employers now pretty much disregard the sick notes that they're given, treat them as fit notes, and are asking people, you know, when can you come back and what mitigations can we put in place to get you back? So that's a cultural change that we need to reverse if we're going to have people actually honestly stay off and not infect other people with infectious conditions that spread throughout the community. This is highlighted by all medical professions, epidemiologists, as just the next pandemic that we're getting. There's going to be more than this. That, you know, there are other pandemics that are going to be around the corner. There are other conditions that are going to be there. And unless we are prepared to support people in their illness, then we are going to be caught red-handed again at the next pandemic, where people are going to be forced into the workplace. The spread of the condition is going to be dangerous, and it might be a lot worse than the COVID that we've experienced, which has been absolutely dreadful, but there could be worse around the corner. Thanks for that.
Thanks for your comments, Mick. I don't think there's anything that the panel here can come back on, but I'm sure they'll take these comments forward. Des Morris, please.
Thanks, Tracy, and I'll be very brief because I've got to go to another meeting at 4. So I might ask this question, but maybe not be here when the answer comes out. But no doubt my colleagues can get back to me. So I'm just wondering if it would be possible to get the longer list of symptoms that Colin referred to, so that our members and, more as importantly, our employers know what those symptoms are, because the Scottish Government guidance says our members must stay at home and self-isolate if they have symptoms of COVID-19. So if it is now longer, if it is now a more expansive list, then I think our members need to know that, and we would welcome absolute crystal clear clarity on that, because our members would have to justify why they're staying off. The other thing is that the underlying assumption now, I think, behind the guidance is that if any of our members want to take a lateral flow test, then they're going to have to buy them themselves and pay for them themselves. I think that is the assumption underlying this. And in light of that, then I'm wondering if one of our members does elect to test themselves, because they're not being recommended or guided to do so, but if they elect to test themselves and do test positive, then is the recommendation that they still, in the absence of any further lateral flow tests, which they may elect or not to take on days 6, 7, 8 or 9, should they then continue to self-isolate for 10 days? Thanks.
Would anyone like to pick up on Des's points there?
I could quickly, Des, before you have to go. So just continue to follow current guidance as it stands. So it's still the same 3 symptoms now. And then when testing is reduced, so the asymptomatic testing program 18th, if the timeline's followed, and then end of April for symptomatic testing, then a wider symptom list would be produced. That wider symptom list is for all respiratory illness, and I can only assume that that is already the advice across all workplaces, whether it's followed or not, that if you are unwell, don't come to work, I would hope. So it's not that we're adding extra symptoms and you're not allowed to not go to work if you have other symptoms that are not on the three list, the three COVID symptoms. I wouldn't recommend someone attend work when they were unwell from a public health point of view, full stop. In terms of the asymptomatic testing, that will have to also be worked out. And it's a very astute point that we need to think through. If someone does buy a private test and get a positive, what do we then advise them to do? And it's likely that they would receive advice similar to now to undertake some isolation period. But I think there's some untangling needed to be done about what kind of motivation that might offer people to take tests or not.
Thank you for that, Colin. I can speak on behalf of everybody to say that our employers do not tell us not to come in. They tell us to come in if we're a bit unwell. I'm sure you can manage. I've even had somebody who tested positive in the workplace last week asked to stay on for an hour because after all, they'd been in there for 2 hours before they decided to test. So I'm afraid that happens kind of widely. It's not, it's something that we need public health to back up on. Any further comments, colleagues, or questions? I'm aware that we've gone slightly over your time, and we're very grateful, and we thank you very much for your time. It's valuable. We are very concerned. I'm sure you've picked up on that. We remain extremely concerned about the effect. Can I just say, not to doubt, because you are the medical practitioners, but on Monday there was 2,128 people in Scotland with COVID, which is higher than at any time ever before since the start of the pandemic. So I know there's less people in intensive care, but as someone who's been in hospital, that's quite a scary statistic. And I'm not sure why we're removing mitigations when we're at this stage. Diane, would you like to speak?
Well, I've been on that because I was going to finish just to reiterate again that just that importance of the vaccination programme, which I'm sure I don't need to repeat to you here, but you know we are at a different stage of this pandemic. So our focus, from a public health point of view, our focus is on hospitalisations, you know, and the more severe consequences. That's what we're closely monitoring. And of course, our advice would change if our view on what was happening there was different than it is now. But we are where we are at this moment in time with the current variants circulating and with the protection from the vaccination programme and the rollout of that continued protection for those that most need it. That is our focus, and the focus on case numbers is almost unfortunate to us because it takes away the focus on the severe end, which is what we really want, which is the real area where we want people to be focusing on now. And then other than that, people getting on with their lives, being careful if they're symptomatic, staying away while they've got symptoms, but getting on with their lives so we can mitigate some of the wider harms that we're all fully aware of that have been caused over the last few years.
Okay, thanks.
And if that answers your question, but that's where we're standing on the public health front. Yeah,
we're just wondering if money wasn't an object, would we be removing these mitigations? Because we all feel that this is all to do with money rather than anything else, to be honest. Andreen, did you want to make a comment?
Thanks, Heather. It's just one last point. I missed the beginning, so I'm really sorry if I'm going to say something that you've already mentioned, but it's really just to go back to that point about the LFTs and the removal of the free LFTs. I take your point, you know, that in the wider society they may not have had the impact that you might have thought, but actually, if right now the point you're making is that people who are unwell should stay at home, and we agree with that. We're always telling people, don't be at work if you're not well. Make sure you go to the doctor. Make sure whatever your issues are, you go to the doctor and you take the time off. That would always be our first line of advice to members. But under the current circumstances, people are feeling incredibly pressurised to be at school, right? And if them being able to demonstrate they've got a test that shows that they're positive, that gives them a bit of confidence to be able to say to their employers, I need to be off right now, right? If that helps, then that surely that there's a cause there. There's a good reason for keeping free LFTs for staff in schools. I know that I think LFTs are continuing for medical care staff. Why can't they continue for staff in schools, even if it's just for that purpose, to give them the ability, the confidence to be able to say to the employers, I have to be off, I have to take time off, because otherwise you're going to have schools even more filled with infectious people because of the people who are trying to get back to work or feeling pressurised to come back to work.
Thanks for that. And if I could just follow up on that, the timing of this is really striking for us, because for the first time in 2 years, our young people are about to enter exam halls and do national qualifications in one large space. And okay, we can open the back door if we're in the gym hall or whatever, but we are really afraid that there could be, in the first couple of days of those exams, major outbreaks, and the rest of the exam diet will be scuppered for these young people, because if they follow your advice and have symptoms and don't go in, then what happens to those young people and invigilators and the staff when they're trying to sit their exams? The timing here to us is absolutely off. It should have been to the summer holidays to allow that fire break, and then to see where we are with the virus when we came back in August. And that's how we feel about it. And we would all reiterate Andrene's point. In fact, we're all writing to the Cabinet Secretary to ask for LFTs to be freely available in schools, because Jason Leach told us he wanted schools to stay open at all costs. With your idea of having to stay home and isolate when the virus takes off, then I'm afraid, like you're seeing today, schools will start closing again because there won't be enough staff in order to maintain the numbers safely for the young people. So on that note, and I'm sorry there's nothing positive to take away from this, but we really are grateful for your time. We absolutely are. Thank you for coming along and sharing your expertise with us. And I'd just like to say to everybody, goodbye, have a lovely evening, enjoy the sunshine if you can, and stay safe. Thank you very much, everyone.
Thank you. Bye.